So yeah, I'm going to talk a little bit about the brief Carl gave me was the research in simulation. So I've tried to stick to the brief. I have no interest, but I have one thing to declare, which is I was having far too much fun yesterday, and a bit like you, I've added in a video from yesterday. So I'm going to talk about the two forms of simulation. There's a lower form of simulation, as my friend here on the left and I had a great time yesterday, and let's call it a higher form of or higher fidelity, as you can see here on the right. So this is me yesterday. Oh, shame the sound's not working. It adds a lot of vibrancy, if you could. So that's me in the back of this bike, going the wrong way up a road, which I'm sure for the locals is pretty normal practice. But I did have an extremely good time, and at the end of the hour, tipped the gentleman what he thought was far too much money, but it was best money I've spent since getting here. And the relevance of this to me was that I'm quite a keen cyclist, as you saw from the last slide, but there's always something to be learned by approaching something in a new way. In exactly the same way we were talking about levels of evidence and gaming. Life's a game. Surgical skills can be considered a game. And how to reinforce it and how to actually absorb it is something that has been described really well. So if you look here, there's loads of highest forms of evidence, systematic reviews and meta-analyses. And that's really what I try to stick to in terms of the brief. But most of these are cataracts. Most of these focus on either high fidelity, some of them on low. Some of them are vitreoretinal, as you can see here at the bottom, which I'll come back to. And some of them are relating to skills labs, which is what I will start with. But in essence, what all of those papers suggest, here, I'll go back if you want to take another shot of that. All of these really suggest that blending all the different forms of education gives you by far and away the best form of learning. So trying to stick to one or the other or a third generally gives you less good outcomes. I think the other thing that's really important, we in ophthalmology, whilst we have all these great forms of education, great technology, have really quite low levels of evidence for educational outputs. And the forms and types of studies that we output are not of the same standard in terms of the viability for incorporation into meta-analyses and systematic reviews. So there's a lot more work that can and probably needs to be done to bolster the evidence. So at the lower end, and I take some issue with the low fidelity side of things because actually these are incredibly sophisticated, bioengineered pieces of kit, but there are quite a few different types, and I've had to play with most of these over the years. So this one you may be familiar with, these as well, the Kitaro here on the left, the Philips Eyes, which is here on the right, and I'll show you a couple of videos of that one. Again, one of the really interesting things about these sorts of kit is that they work much better when they're integrated with other forms of learning. So in a lot of the cases, certainly in the Philips Eyes, you've got an online resource where you can try and blend, and as you can see here at the top, you've got all the different types of subspecialties, and you can try and blend what you're doing practically with what you're doing cognitively and what you're trying to learn. I'm not a squint surgeon, but having had a play with this, and from what little memory of squint surgery from many, many years ago, it does certainly seem and looks realistic, and you can see from the videos here, that they seem to blend extremely well. And again, that systematic review and others do seem to suggest that putting these together can be extremely useful. In addition, you've got a lot of standalone platforms, so simulation in a more immersive setting, if you like, or more educational setting. So this is one example where you sit online and you learn prior to then going in, and so just-in-time simulation and various other forms of core learning. And this is far from an exhaustive list. There's a tremendous amount of great resources. There's Paul Sullivan's series, there's a whole load of online, a lot of other interactive stuff, which I think is extremely valuable. Again, sticking to the brief, the amount of published research on it, unfortunately, is quite low, but there are some extremely good bits of kit out there, which I'm sure will enter the more academic sphere. There have been some good papers on these two. So now moving on to the higher end of simulation. So we're looking at two platforms that have more recently entered. They've got much less evidence available on them, and they're, I think, less widely available than some of the other platforms that I'll come on to. But Immersive Touch is a North American platform from the USA, and it's basically an immersive company. So they deal with patient outcomes in an immersive setting, and they've moved into a more haptic type feedback. The Swedish company on the left here are more for a basic modular end of phaco training. The other company that have gone into the haptic feedback are Alcon, so they've recently released this one, which if you've had a play, is again very good. The main aim and the main part of the market is to be portable, and they've integrated it with their Centurion foot pedal. So those of you who do cataracts and use the Centurion, there's a good crossover there. It also fits in quite well, these haptic feedbacks, with the 3D viewing platform. So again, those of you who do cataract surgery, any of you who've tried these immersive, so these are the non-binocular, because you're not using a microscope. You put the 3D glasses on, you're using now a big screen. Ergonomically, it's very different. So for those of you who do cataract surgery, and like myself, for the last 25 years, have used to do it one way, it's quite an ergonomic change to be looking at a screen away from the patient. But there are some potential benefits in terms of posture, in terms of certainly the teaching side of things, because you can have a large number of people, rather than just having a beam splitter, wearing the 3D glasses and actually getting a much better educational experience in the room. There are a number of other non-cataract related platforms. Almost all the vitreoretinal ones evolve around the VR Magic platform, which is an exceptionally good, but I'm not going to really focus on it, so apologies to any vitreoretinal surgeons in the room, because it is quite niche. There's a much bigger set of immersive platforms, and a much bigger set of simulative platforms for clinical training, which again, I'm not going to go massively into. Again, VR Magic have a big part of this market, but there's a lot of mobile phone related and other type apps which are brilliant, and I'd encourage you to look online for a lot of these. I think in the interest of time, I didn't go through those in more detail, but it's also guided much more to primary care as well as our own juniors. The IC, of course, has got the largest share of the market. That's the one we're most familiar with. And I think any of you who have used the machine are very well aware of many of its benefits. So it's very good at transferring skill, got lots of cataract-specific and generic modules. And there's quite good evidence that it does transpose an awful lot of skill, and it does make people generally more competent surgeons in cataract. That's, I think, quite well known. So what else has come along in the last few years? Well, the pandemic forced, obviously, a rethink of telementoring and remote training. And we took it upon ourselves with the social distancing in London to basically set up a remote platform. So what we're doing here is setting up a dial-in facility with a phone. We're outstreaming from the IC into the phone, into the laptop. And what that's allowed us to do is then remotely do the training. So that was very useful during the pandemic, but actually it's turned out to be incredibly useful. So I can train someone the other end of London. I could train someone here as long as we get our time zones right. So it's, I think, opened up the equitability of simulator access. Trainee can then go to the simulator that don't necessarily need to wait for the trainer to go there. And it's a really straightforward, simple, just need a mobile phone and a cable, out cable. So it's well worth, we've published this if you want to look at it. It's just a little, tiny little paper, but I think it was a useful addition. I've just stepped down from my role as the Royal College virtual and augmented reality lead, and we did a big piece of work looking at cost effectiveness. And these platforms cost a lot of money. And I remember talking at one of Carl's sessions about 15 years ago at the World Congress, and the hand went up saying, that's more than our entire annual budget. And they still are extremely expensive. Are they worth investing in? There's a lot of money to suggest that there is good outcomes. And this is, again, it depends on what your budget is, but if you've got the money, they definitely can offer huge potential benefits. So this was the NOD is it's a large pooled big data analytics set of research, which is done jointly with the Royal College of Ophthalmologists, and it pulls tens and tens of thousands of cataracts. As you can see here, this study looked at just under 20,000, just over 15,000 cataracts, and it basically found at about just under 40% reduction rate in PCR with the introduction of simulators. So that just shows the transposition. That was a really good level of evidence that highlights the benefits of high fidelity simulation, of course, in conjunction with the lower fidelity side. Now I'm going to run over by the looks of it. So the Help Me See are a charitable platform which have produced an incredibly good set of technologies, again, in conjunction with their whole course. So this is the MIG simulator, and very usefully, they've come out now with the phaco simulator as well. So if you get in touch with them, very well worth having a play. It's a charitable organization. It's all geared towards the third world. So whilst I've interacted with them a lot and I've had a play with their tech, we don't have one because we're not, well, some people might consider us, but we're not officially under the domain of what they're targeting. The other great innovation is Orbis. They have also developed now a high-fidelity simulator. This one I've not had a play with. Again, it's a haptic base, so very much like the other two. So again, I think this is incredibly exciting for opening up training to surgeons delivering around the world. This is the immersive. This is a huge area outside of ophthalmology that we haven't really adopted, and this is all about case-based and learnings from a cognitive, situational awareness, etc. point of view. And I put this in really for completeness. We did a trial on this, and there have been some peppered bits of evidence, but it hasn't been broadly adopted for whatever reason in ophthalmology. And there's some incredibly useful robotic platforms coming through. Again, these are all mainly vitreoretinal, so I've put them up for completeness. But I think this is going to be a huge area with AI integrating and additional degrees of stability. So the AI is the last thing I'm going to talk about, which many of you will know AI from various other domains. We developed a platform with Medtronic, so I'm just in the last few seconds, which I have actually run out of time. Let me just show you what we developed. This is basically an AI platform that in real time tracks cataract surgery, and it's incredibly useful, not just for the surgeon or the junior who's doing it, because it does phase transition, but it's operationally very useful. So you've got, this is the AI device. It tracks into your mobile. It's got a couple of extra screens in theater. And what you'll see here, in real time, it can then show you the phase that you're in and give you all the live metrics and analytics. And why that's useful is in terms of team training. If you've got your nursing staff who may be changing over or less familiar, they'll know that I will take X amount of time during my phaco, I'm about to overrun, what instruments I'm likely to use next, and because it can do all the tracking and recognition, it can then put that up on the main screen, which can then help with operational flow, operational getting patient throughput and safety, etc., rather than just the actual feedback for the surgeon. So this is as a team training and as a broader area, this may well have good applications. Sorry, I'm a few minutes over, but thank you very much.
Any questions or comments right at the moment?
Just pull it out.
Question?
Hi, great talk, George. Just
Thanks.
a comment. Our college, the Royal Australian New Zealand College of Ophthalmologists, we mandated IC training a few years ago for all our trainees. But be careful what you wish for, because all of a sudden then we had to buy enough simulators. And so I guess my concern is that does this then become a one-horse race for us? We're kind of narrow-casted into this one platform. And so there are going to be issues for us if a cheaper one comes along later, and yet we've mandated one. In your experience, is there interoperability between these, or is it like a Zeiss? Humphrey, you're stuck with it forever.
It's a brilliant question, and that was a big part of the report that actually should be publicly available in the coming weeks. I have finalized it, it's all been ratified. And in that, what we have looked at is the enormous cost, in our case, to UK PLC, which has many dozens, I'm not allowed to say exactly how many, but at the end of the 10-year lifespan, they then need renewal. They also need service contracts and so on and so forth. I see at the moment, I still take the view, I'm very grateful IC have invested and generated this tech, because it's created an awful lot of safety and saved an awful lot of eyes, even though it's incredibly expensive. I do suspect some of these other platforms will come on and rival. When, we don't know. So I think what we have tried to do is, as a country, is negotiate a bigger block contract, and the company are very willing to do that. If you're willing to purchase an X number knowing that you're going to renew, then, so I think you then have a purchasing power potential, and that might be an approach. They have engaged with us very well. It's actually our side getting the country to agree between themselves where you're going to place the simulators, how each trainee is going to be able to access. We have regional variants like we would do here and I know in the States. So are you going to allow your rival region to come in and use, and then what happens when they break? The probes are very expensive. So there's a lot of caveats to it. Until a technology comes along that rivals it, withdrawing it, we concluded, is a major safety risk. So it's something that we have to fund, because the evidence is now there until an alternative comes along.